If you've caught Joe Rogan's podcast recently, or if you've been listening to announcements from the Oval Office about acceleration of potential innovative treatments for mental health and addiction, you've probably heard someone talking about a plant-based psychedelic from Africa that is going to end the opioid crisis. One dose, addiction, gone.
And I had a good friend, my friend Ed Clay. He went down there because he hurt his back and he got on pills and he couldn't get off them. Did Ibogaine, got off them. He's like, oh my God, like more people have to be aware of this. This really works. It's incredibly effective. There's nothing like it.
Hello and welcome to the Dr. Suzette Glasner podcast. Here's a specific set of statistics that have been making the rounds.
It's in the mid-90s.
That's fucking amazing.
Yeah, people that never go back to the drugs. Never go back to whatever it is, gambling, whatever you have, whatever's wrong with you.
All you got to do is figure out what's wrong with you.
Yeah.
Now that is a staggering claim, and I want to be really clear and precise because it's a claim that is rooted in a real study, but the way it's getting repeated and communicated on podcasts is distorting what was actually shown. And this isn't just a podcast moment anymore. Now that the Trump administration has announced it's going to accelerate federal research on Ibogaine and other psychedelics for mental health and addiction.
Trump for making this historic day possible. Under the executive order, HHS will accelerate research, approval, and access to new mental health treatments, including psychedelic therapies such as Ibogaine. We're taking this decision, this decisive step, to confront one of the most urgent public health challenges facing our nation, the mental health crisis.
Now, as an addiction treatment scientist, I am thrilled to see the acceleration of discovery and clinical research on promising and innovative medication approaches to treating addiction, such as Ibogaine. That is something that is desperately needed in our field, and currently it moves far too slowly. What I'm concerned about is the way in which the promise of this medication is getting communicated, and some of those very shiny statistics and very exciting potential outcomes of a treatment of this nature are being communicated because they're distorting the reality of what the studies actually found. The rigor of the studies isn't quite there yet. And when you get people really excited about a potential cure and you inflate the statistics associated, people tend to act on that. And that is what worries me as a clinician who treats addiction and has experienced the desperation that people with addiction to something like opioids and their families experience around wanting desperately to see their loved ones get well. This is where people sometimes make uninformed decisions about the pursuit of a novel medication under conditions that are not safe or haven't been established to be safe. And that's where we have seen some tragic outcomes in the past. So the question that I've been asked since this announcement in the White House was released is Ibogaine really the cure-all for opioid addiction that it's being made out to be? And my honest answer, and the reason that I wanted to do this episode, is that I'm concerned because while the science here is genuinely promising, and I am 100% behind the acceleration of research into the clinical outcomes and safety of this medication, the gap between what the evidence actually shows and what people are hearing on podcasts and in other public forums is large. And that gap is where people can get hurt. So today I'm going to answer 3 questions. First, what is Ibogaine and what does it do in the brain? Second, what does the actual evidence show about Ibogaine for opioid addiction? Why should we be cautious about touting it as a miracle cure? Third, the key questions that you need answers to. Is it really safe? So let's start with what is Ibogaine. So Ibogaine is what we call a psychoactive compound. It's from the root bark of an African shrub called Abernanthe iboga. In parts of West and Central Africa, it's been used for centuries for Bawiti spiritual ceremonies. So this is really not a new molecule. The Ibogaine for addiction story in the West really starts in the 1960s. There was a 19-year-old individual by the name of Howard Lotsof who was addicted to heroin and recreationally took Ibogaine, just expecting to get high or have kind of a dissociative experience. And what he reported was that when the experience ended, about 30 hours later, his withdrawal was gone and his cravings had essentially disappeared. So he became a very passionate advocate, as you can imagine, for Ibogaine as an addiction treatment. One dose, lasting about a day, producing effects that last weeks to months. That is the claim that has kept this drug in the news for 6 decades now. And I want to flag right up front that anytime someone tells you that a single dose of anything will fix a chronic relapsing condition, your skeptic alarm should be going off. I do believe that miracles are possible, but only data can prove it, and we're not quite there yet with Ibogaine. We're seeing a lot of signs of promise, and I am excited to see where this goes next. But evidence of a miracle cure for addiction, we don't have yet. So how does Ibogaine work in the brain? So here's where the science is actually very interesting. Unlike psilocybin or LSD, which mostly act on serotonin 2A receptors, Ibogaine hits a lot of different targets in the brain at once. So I'm going to name off a bunch that may not mean anything to you, but we can dig into them a little bit more. You can do some research on them. The NMDA glutamate receptors, kappa and mu opioid receptors, sigma 2 receptors, nicotinic acetylcholine receptors, and the serotonin transporter. The target that excites addiction researchers in particularly is something called GDNF, and that is glial cell line derived neurotrophic factor. In animal studies, Ibogaine appears to boost this GDNF in an area of the brain known as the ventral tegmental area, and this is really at the heart of the brain's reward circuit and gets what we refer to as hijacked in addiction. So boosting GDNF in that region reduces how much animals will self-administer various substances, including alcohol, cocaine, and opioids. So what Ibogaine may be doing is something our current medications don't, which is nudging the reward circuit itself. And that is a real finding and is very promising. And it's why serious scientists really care about this drug and want to see it through in terms of rigorous research. There's also a subjective piece. So when people use Ibogaine, they describe this sort of intense waking dream state that they find themselves in. That's where they experience memories, often trauma. And whether that psychological experience is part of the therapeutic properties of this medication or just a side effect is really still an open question. Now we're getting to a very important question, which is what does the clinical evidence actually show about Ibogaine for opioid addiction? This is where it's really important that we're transparent about what we know Ibogaine has done and not done. So the animal studies are very consistent. Rodents will self-administer less morphine, cocaine, alcohol, and nicotine after Ibogaine. Withdrawal signs drop. Those findings have been replicated and are pretty robust. But in humans, here's what we actually have, and here is what we don't. We have observational studies from Ibogaine clinics, mostly in Mexico and New Zealand, where Ibogaine is either unregulated or legal. There are several researchers who have published follow-up studies of people with opioid addiction after a single Ibogaine treatment, and the majority do report big drops in opioid use, withdrawal, and craving. And a meaningful subset will report that they are still abstinent at 12 months, and that is a signal. But there is a limitation of what we refer to as observational studies. We cannot isolate when we're observing somebody over time taking a medication and seeing what happens. We cannot isolate that all of that is just because of the medication. They could be doing lots of other things. They could be highly motivated. People who will travel to another country in order to get access to an innovative treatment are highly motivated, often with resources that other people don't have. Not always, but that's often the case. They're often doing other things in the interest of their recovery after they return. To study the impact and isolate the impact of medication like Ibogaine, you need to have someone to compare those individuals to. Other people who are highly motivated, other people who are doing a lot of the same things, and they only differ in terms of one group receiving the Ibogaine medication and the other receiving either some other medication or a placebo or something like that. When you don't have that comparison group, you're very limited in what you conclude is attributable directly to the medication. So now let's talk about, in relation to this idea of rigorous research and clinical trials, which are needed and have not been conducted on Ibogaine, that 80% cured number from the top of the episode.
With one dose of Ibogaine, more than 80% of people are free of that addiction. With 2 doses, it's more than 90%.
Because when I traced it back, it almost certainly came from a study that was published in 2018 in the American Journal of Drug and Alcohol Abuse. It is one of the most cited studies by Thomas Brown and Kenneth Alper in Ibogaine advocacy. So let's look at what they actually found. That study enrolled 30 people in total at an Ibogaine clinic in Mexico. We don't have a group to compare them to. We don't have a placebo medication or other medication to compare this to. These were individuals who were already going to an Ibogaine clinic in Mexico. And when they looked at them at 1 month follow-up, they weren't able to reach all 30 individuals. They reached 19 out of the 30 individuals. Now, out of those 19, 79% of the 19 people they reached reported no opioid use in the prior 30 days. That is where your 80% comes from. But if you look at what that number actually represents, 79% of the people they could reach at 1 month, that's actually 15 out of the original 30. So that's actually 50%, not 80% of the people who were originally part of this research study who gained access to Ibogaine. Now, in clinical trials research, when we're using conservative methodology, conservative methods of interpreting and analyzing the way that a medication impacts a certain outcome, like substance use, we don't change the denominator based on how many people respond. We look at everyone. So if we're looking at everyone and the denominator is 30, we know that 50% of them were reporting no drug use at 30 days. That's still good. That is still a signal that this medication is worth studying, but it is quite different from saying that 80% of people are cured. And that's a really important difference. By 12 months, only 12 of the original 30 were reachable, and 9 of them reported no opioid use. So that's 30% of the original sample of 30 people were reporting no opioid use at 12 months. 30% abstinence at 12 months in a small, uncontrolled, self-selected sample who traveled to Mexico for treatment is an interesting signal. If it were up to me to fund and accelerate research on a medication like this, I would stamp it a yes. But it's not 80% cured with a single dose. It's not even close to that. So this 97% with a second dose figure, I actually couldn't find that in a peer-reviewed study. That might be related to clinic-reported outcomes and is all part of a relevant picture for justifying accelerated clinical research to really understand how efficacious this medication is, who it works best for, and whether it's safe. And those are the 3 questions that we really need to answer at this stage of Ibogaine research. Now, in 2024, there was another Stanford-based published study on Ibogaine that was co-administered with magnesium, which is really important from a safety standpoint, in special operations veterans with traumatic brain injury. And this was the population that was referenced in the recent press conference in the Oval Office around the promise of Ibogaine and other psychedelic medications and the reasons that they're being accelerated in clinical research. They showed large improvements in PTSD, depression, and anxiety. This is a very important study and worth paying attention to. But the gap in all of this is that we don't have a single large randomized clinical trial for Ibogaine for opioid use disorder. Not yet. And that matters because the people who are showing up at Ibogaine clinics in Mexico are a self-selected group. Usually they can afford it. They're very motivated. They're flying to another country in order to gain access to an innovative treatment. They believe that it will work, and they're often pairing it with other recovery supports when they come home. And every single one of those factors boosts outcome. So we don't have an unbiased test of Ibogaine as a drug. We have tests of motivated people who get Ibogaine. We have to be careful. And the reason that we have to be so careful about what we say about Ibogaine and what we communicate publicly is because when we tell people with a chronic brain disease that a single dose of something is going to fix them, we could be setting them up and their families up for a disappointment and for a rush to decide and access the treatment in a way that is not safe. So this is the part I want you to hear most clearly because it's the part that gets left out of viral podcast clips. Now, if you listen to the full episode with Joe Rogan, Rick Perry, and Brian Hubbard, they actually have a very meaningful conversation about safety and about the cardiac risks and what has been found in studies. The problem is that people often don't listen to a full 1 or 2 hour podcast. They hear the viral clip and then they go running for a treatment without knowledge of the safety concerns or some of the steps that they need to take in order to protect themselves. I just want to emphasize this and break it down for you. Ibogaine blocks a heart channel called your hERG, and blocking hERG prolongs what is referred to as the QT interval. And a prolonged QT interval can trigger a fatal heart arrhythmia called torsade de Pointes. Now, this is a lot of jargon, but what a QT interval basically is the amount of time the heart's electrical system takes to reset itself after each beat. So it affects the timing of the next beat. And that reset in someone with a prolonged QT interval takes longer than usual. And if the heart tries to beat again before the electrical system has reset itself, the electrical signals can get scrambled, and this can lead to dangerous, irregular heart rhythm. The risk is especially high if you have an underlying heart disease, electrolyte imbalances like low potassium or magnesium, or if you're on methadone, which also prolongs the QT. So a lot of what I just described is the population of people who are likely to be seeking Ibogaine. So when we say it should be available to everyone in America, in its current form, it actually shouldn't, because available to everyone would mean that it's available to people on methadone, people with undiagnosed heart conditions, people with electrolyte imbalances from substance use. And for those people, an unmonitored Ibogaine session is not a cure. It's actually a risk for a potentially fatal cardiac event. There was a review by Kenneth Alper and colleagues documenting 19 deaths associated with Ibogaine use between 1990 and 2008, and there have been more reported since. It's something that we really need to be mindful of. And what concerns me about this current moment is that these public conversations are way ahead of the safety data. People are hearing minor risks, major benefits, and the real picture is closer to potentially major benefits, but documented serious and potentially fatal risks that require real cardiac monitoring to manage. This is why every credible Ibogaine protocol now requires a lot of controls and safety precautions in place related to cardiac functioning, cardiac screening, EKG monitoring during the session, co-administering magnesium to mitigate those risks. It's also why researchers are pivoting towards nor-ibogaine, which is a less cardiotoxic metabolite, and synthetic analogs that seem to keep the anti-addictive effects in animals without the cardiac risk. This is probably the more important story in this space rather than classical Ibogaine. Here's my take. 1, the scientific signal is real, and it's real enough to study very seriously, and the acceleration of research for innovative medication treatments for opioid addiction is something that we urgently need. So federal investment in rigorous trials is a great thing. Speeding up that process has the capacity to save and change lives. As an addiction researcher myself, I am painfully aware of the slowness of the process of acquiring grant funding, completing a study, disseminating the findings, and then pushing new treatments out into the real world. It takes way too long. The shortening of this cycle is very exciting and very much needed. Something that Joe Rogan and that public discourse that he facilitated is really helping to realize. Number two, the one dose cures addiction is not what the data says currently. It's a story that is overselling a drug that is in early stages of research. So it's important that we all proceed with caution and some degree of skepticism about what the data actually show. Third, if you or someone you love is considering an underground Ibogaine experience because a podcast made it sound like it was safe, please get a full cardiac workup first. Disclose every medication that you're taking. Do not use it while you're on methadone or with an untreated heart condition. Fourth, keep in mind that for opioid use disorder today, right now, we already have FDA-approved medication options that are highly efficacious. Buprenorphine, methadone, naltrexone, they dramatically reduce overdose risk and they help people to rebuild their lives. I have seen this firsthand in my clinical practice, and I have led research studies that have confirmed it. These are not quick fixes and they're not magic bullets. And so they may be a little less sexy and a little bit less exciting than the idea of a single dose cure-all treatment, but they are the evidence-based first-line treatments. They're the first step and they're available now. The clinical trials and the safety data are in. Ibogaine trials still await, and I look forward to seeing their outcomes. So let's stay curious. Let's challenge the status quo. That's the only way that we advance addiction treatment science. And let's accelerate research and discovery. But please, let's stay careful and let's stay safe. I hope you learned something valuable, and I look forward to seeing you next time.